So in the last section of this chapter, we're going to talk about traumatic spinal cord injury. There are some other different specific disorders affecting the spinal region in Chapter 18, and we are not going to talk about those in this course. They're interesting. I mean, if you get a chance, look through that section. There's interesting information, but we're not going to talk about it. Okay. So for this section of the PowerPoint, the learning objectives are, I want you to be able to define and describe the specific autonomic dysfunctions in spinal cord injury, which we will talk about. And they include autonomic dysreflexia, orthostatic hypotension, and poor thermoregulation. I want you to define the difference between a complete and an incomplete spinal cord injury. There's a specific definition for that. And I want you to know how the neurological level of a spinal cord injury is determined. I also want you to there's a chart on page 378 regarding the functions that are lost at specific spinal cord injury levels. And I want you to be familiar with that chart. So if I were to ask you a certain level, you would be able to say, or if I were to specify a certain loss, you would be able to equate it with a certain level. So traumatic spinal cord injury is usually caused by motor vehicle accidents, sports injuries, falls, or penetrating wounds. So the first three, motor vehicle, sports, and falls, typically do not sever the spinal cord. The damage to the spinal cord is due to crush, hemorrhage, edema, or infarction. However, I do know one person that was in a motorcycle accident and had a penetrating wound. So you can have that, but typically that's not the case. Penetrating wounds by a knife or bullet or a fence that you ran into typically directly sever neurons in the cord. So immediately after traumatic injury to the spinal cord, all of the functions below the lesions are depressed or lost. And this is known as spinal shock. So in spinal shock, people lose somatic reflexes, including stretch reflexes, withdrawal reflexes, and cross-extension reflexes. They lose autonomic reflexes, including smooth muscle tone and reflexive emptying of the bladder and bowels. They're either lost or impaired. You lose autonomic regulation of blood pressure, resulting in hypotension. And you lose control of sweating and the erection of hairs or piloerection. So several weeks after, so this is immediately after the injury, several weeks after the injury, most people experience some recovery of function in the cord, leading to the return of reflex activity below the lesion. But usually, typically, the return of sacral reflexes is used as an indication that spinal shock has subsided. So the medical team is going to regularly assess for the return of those sacral reflexes and to see whether the person is still in spinal shock. So really the upshot of that is that you're not going to know right after a traumatic spinal cord injury what the extent of the injury is ultimately going to be. And typically in the acute care of a spinal cord injury, they're giving people anti-inflammatory medications, corticosteroids sometimes, to help reduce the potential ischemic injuries from inflammation from that crush or hemorrhage or edema. So because of the extra edema and potentially ischemia, the descending tracts that supply all of those different things are interrupted, and then when the edema subsides, you find out exactly how much you get back. So that's what I just said, but I didn't change the slide. So you lose these things during spinal shock, and then in a few weeks after injury, the spinal shock subsides, and then you see how much you have left. So a lot of times they get the return of reflex activity below the lesion. In some people, spinal neurons become excessively excitable, which results in stretch hyperreflexia. And hyperreflexia develops as neuroplasticity produces new synapses in the reflex pathway. So they get elevated response to reflexes. So spinal cord injuries are classified according to two criteria. One is whether the injury is complete or incomplete. So the definition of a complete injury, complete spinal cord injury, is lack of sensory and motor function in the lowest sacral segment. An incomplete injury, you get preservation of sensory and or motor function in the lowest sacral segment. So if you have just sensory function, it's an incomplete injury. If you have just motor function, it's an incomplete injury. If you have neither, it's a complete. So the neurological level of the injury is the most caudal level, so the lowest level, with normal sensory and motor function bilaterally. So you might have normal sensory and motor function, let's just say in T2 on one side and T4 on the other side. So the neurological level is considered T4. So it's the lowest level with normal function bilaterally. So this is the American Spinal Injury Association international standards for neurological classification of spinal cord injury, and this is used across the board by neurologists, physical therapists, etc., to classify spinal cord injuries. So motor scores are recorded on the left half of the form, ranging from 0, which is complete paralysis, to 5, normal. There are 2 columns, right and left, to record the scores of the listed muscles. So every muscle is tested. To the left of the columns is a list of segments of the spinal cord, and sensory scores are recorded on the right half of the form. So scoring criteria are listed on the box, on the form, and areas of impaired or absent sensation can be indicated on the dermatome diagrams. At the bottom of the motor and sensory sections are small boxes for totaling motor and sensory scores, and the neurologic level is recorded at the bottom of the form. So it's a very specific criteria, a set of criteria for classifying spinal cords. So it's a standardized assessment, so you have consistency in classification. So there are key sensory points that are tested, and then muscle testing on the left and right sides of the body. So the whole point of having that consistency is so then you know what functional ability that person should be able to expect. So there's a table on page 374 that has functional abilities associated with complete spinal cord lesions at various levels. So has from C1, C2, C3, all the way down to S4, S5, and what you can expect in terms of motor capability, intact sensation, mobility, ADLs and transfers, limitations. I'm not going to test you on this in this class. You will definitely do more of this in your neurorehab class in the spring. But these type of questions like to show up on the board exam, saying whether you can expect someone to live independently with a certain level of spinal cord injury. So really the level for independent living is considered to be C8 and below. Anything above C8, someone will need assistance. Sometimes it's like C7 is independent except for floor and wheelchair transfers. So you can take a look at that chart. I'm not going to test you on it in this course, but you will need to know this information at some point. So don't stress on it right now, but that's a really nice reference for later. So there is autonomic dysfunction in spinal cord injury. It makes sense, right? Because the autonomic system is a vertical tract system. So during spinal shock, you lose neural control of pelvic organs. And so you do need to be catheterized, and a lot of times in acute care, they are teaching the person how to self-catheterize. Bowel and bladder walls are atonic, allowing overfilling of the bowel and bladder, and you get overflow leaking. You can avoid overflow leaking, which can end up causing a problem with infection, by establishing a regular bladder and bowel emptying routine. And so that's a lot of times, that is one of the things that's being taught in acute care is catheterization for bowel and bladder. So complete lesions at higher levels of the spinal cord cause more serious abnormalities of autonomic regulation. So in that chart on page 378, it talks about what the levels of the lesion and what kind of autonomic dysfunction are associated with individual levels of lesion. So loss of descending sympathetic control as a result of lesions above T6 results in 3 major autonomic dysfunctions, and these I want you to know. Autonomic dysreflexia, poor thermoregulation, and orthostatic hypotension. So autonomic dysreflexia is a medical emergency that can affect people with spinal cord injuries above T6. T6, know that. So the immediate life-threatening concern when someone experiences autonomic dysreflexia is having a stroke, because it elevates your blood pressure dramatically. So that elevation of blood pressure can cause a stroke. And so if someone's already got a spinal cord injury, they really don't need to have a stroke in addition to that. So that's why it's a medical emergency. So autonomic dysreflexia occurs when an unperceived noxious stimulus below the level of the injury elicits uncoordinated autonomic control response that cause elevated blood pressure, pallor below the lesion. So if someone had a T4 lesion and they were pale below their lesion, you might not be able to detect that. But if you're monitoring their blood pressure, you would detect the elevated blood pressure, sweating and flushing below the lesion, and a reduced heart rate. The other thing, sometimes you'll get some pupillary response, and so you really want to watch your spinal cord injured patients closely for those type of responses. Often a noxious stimulus can be something like a kink in a catheter hose can cause that. So that it's something that you should really be aware of with spinal cord injured patients. So the first thing you want to do is you want to, activate the EMS system. If you're not at the hospital or in acute rehab, if you're in an outpatient setting, you want to get EMS on the way. And then you want to monitor their blood pressure. You want to, if they're standing up, you want to lie them down. If they're like in a standing frame, you want to lie them down. If you're working on them on a tilt table, perhaps, to work on upright tolerance, you're going to lower the level of the tilt table. So it's an emergency. You need to deal with it right away. Poor thermoregulation may interfere with the ability to maintain homeostasis. So people, because of the interruption in the autonomic tracts, they lack the ability to sweat below the level of the lesion, so they may compensate by excessive sweating above the level of the lesion. People with complete lesions above the T6 level should avoid exposure to high ambient temperatures, because there's a really high risk of heat stroke because their body cannot compensate enough. Signs of heat stroke include high body temperature, rapid pulse, and dry, flushed skin. Signs of hypothermia include irritability, mental confusion, hallucinations, lethargy, clumsiness, slow respiration, and slowing of the heartbeat. So both of those, heat stroke and hypothermia, are potential consequences of poor thermoregulation. So what we can do in a therapy setting is we can make sure that the room is comfortable. It's not too cold, it's not too hot. People have coverings as they need. or uncoverings as they need. So a lot of times we can control the external environment. We can't really control what's going on with the person. Orthostatic hypotension, it's not exclusive to spinal cord injury. We've talked about this before, but it's a 20 millimeter of mercury or greater fall in systolic blood pressure, or a 10 millimeter of mercury greater fall in diastolic blood pressure upon assuming an upright position. So in people with spinal cord injury, orthostatic hypotension results from the loss of sympathetic vasoconstriction combined with the loss of muscle pumping action for blood return. So a lot of times with SCI, we're getting people into a standing frame because it's good for them. It's good for their body to stand up till you get more of that muscle pumping action, and you get them out of that chair position. It's just better all around for digestion and circulation and bone density. So a standing frame is a really good intervention for someone with a spinal cord injury. However, you don't want to stand them up and have their blood pressure plunge down. So I've worked with people with spinal cord injuries where we were working on upright tolerance because we wanted to get to a point where maybe they were standing in the parallel bars or using knee, ankle, foot orthoses to stand, or some sort of thing. But we had to work on the orthostatic hypotension problem to begin with. So what usually we'll do, have someone on a tilt table or in a standing frame, gradually bring them up maybe 5 to 10 degrees at a time, monitor their blood pressure the whole time. As soon as it starts to drop down, you take them back down. So I've had sessions where I spent an hour getting someone up to 45 degrees. And it was worthwhile because that person eventually was able to stand using knee, ankle, foot orthoses, and able to do things on his own in his home that he wouldn't have been able to do otherwise. He could stand up at the sink for his grooming. He could stand and reach into upper cabinets. So by working on this at an earlier stage, you can actually get him more functional at a later stage and more independent, which is great. So severed axons in the adult spinal cord will not functionally regenerate. So the prognosis is not good for complete regeneration. Barriers to regeneration include inhibitory molecules on oligodendrocytes, glial scarring, just like we talked about before, and decreased rate of growth in mature neurons. So some functional losses after spinal cord injury are not due to the original injury. Rather, they're due to secondary changes such as bleeding, edema, ischemia, pain, and inflammation. So that's why in the acute care setting, they really try to control some of those things so there's a better prognosis later on and you don't have as much functional loss. So typical complications after spinal cord injury include urinary tract infection, spasticity, chills and fever because of that poor thermoregulation, decubiti, which are pressure ulcers, and autonomic dysreflexia, contractures because of inability to voluntarily move, and heterotopic ossification, which is formation of bone in areas where it doesn't normally form, and pneumonia, because without the abdominal muscles innervated, you lack a good cough reflex. Things can build up in your lungs. In your neurorehab lab, you'll be working on assisted coughing with people. One of the guys that I've worked with a lot with a spinal cord injury, he said that he feels like he's really got a big sneeze coming up. He's got like a T8 heavy section of the cord, or incomplete, and he said he feels like he has a really big sneeze coming up, and then it comes out as like this little kitten sneeze, like a cheep. And he said it's very disappointing to not be able to do a big sneeze like that. But upright posture can provide some protection against urinary tract infection and pneumonia, so that's why we use a standing frame. Mobility can help avoid contractures and decubity. So we want to teach people pressure relief maneuvers that they can do. We want to teach them transfers and mobility. There's a lot you can do with spinal cord injuries. One of my favorite spinal cord injury patients over the years, I've worked with them on a lot of different things. A lot of times when you're working with someone with a chronic CVA or spinal cord injury or MS or something like that, you're forming a relationship with this person. Hopefully you're going to be working with them for a long time. It might not be continuously for a long time, but they'll come in, you'll work on some issue that they're dealing with, help them with it, and then they'll discharge from PT, and then they'll come back and they'll work on something else. So you form relationships with these people, and it's great. That's one of the things I love about neuro rehab. So one of my SCI patients, he said that he has a T7 complete injury from getting hit by a bus, and he's a wheelchair for mobility. He's has a hand control car, very able. But he said people will ask him, like, oh, do you think you'll ever walk again? And he says he doesn't even care about walking. He's happy that he can manage his urinary tract issues. He said, like, not getting a urinary tract infection, that's success for him. So everybody defines success differently, and it's not always walking. So red flags for the spinal region, signs and symptoms that indicate a spinal cord lesion are bilateral alteration or loss of somatosensation, incoordination, and motor tract signs, including decreased muscle power, spasticity, muscle hypertonia, Babinski sign, and clonus. Signs and symptoms that indicate a possible cauda equina lesion are difficulty with urination or defecation, decreased or lost sensation in the saddle area, low back pain, unilateral or bilateral sciatica, lower limb paresis and sensory deficits, and decreased or lost lower limb reflexes. So if you have a lot of times the thing that people come in for or come into outpatient for with cauda equina syndrome is back pain or sciatica. I was working with a woman a couple years ago, and she was sent in for low back pain. And, I've said this before, everybody gets sent in for low back pain. That is such a common diagnosis. So she came in, and our scheduling people, they schedule with the therapist based on diagnosis because we have a lot of different therapists. So really this woman should have been scheduled with a neurological therapist, but she got scheduled with an orthopedic therapist because of her diagnosis of low back pain. The orthopedic therapist, not being as familiar with the red flags for the spinal region as the neuro side of the group, she was treating her as she would treat an orthopedic patient, so with manual therapy and exercise. Well, third or fourth visit comes along and she's on my schedule, and she's telling me about her difficulty with urination, the sensation issues, the paresis, decreased limb reflexes. Of course, she didn't word it that way, but that's so she had a lot of these red flags. So I went and talked to the PT, and I immediately emailed the doctor and said, we've got something else going on here. This isn't mechanical low back pain or orthopedic low back pain. And cauda equina is treated medically. It's not treated with physical therapy. A lot of times after they're over the initial inflammation, they come into physical therapy to regain their strength and balance and everything. But the initial treatment needs to be medical. And so the thing to do with that is to absolutely refer back to the doctor. So she left physical therapy, went back to the doctor. And, you never know what happens to people when they're out of your jurisdiction. And so I don't know what happened to her, but I hope she got good medical treatment. But it's good to know these red flags. Signs and symptoms that indicate intermittent claudication. So intermittent claudication is leg pain upon walking that stops with rest. So pain in the buttock, posterior lower limb, and or foot while walking or exercising that disappears after a brief rest. Decreased pulse in the lower limb and cyanosis in the lower limb. So usually, these type of symptoms, intermittent claudication, can indicate a neurological rather than an orthopedic origin for the problem.